Welcome everybody. Hopefully you've looked at the previous slides looking at what is a risk factor, and this time we're going to talk about the distribution of risk factors and how they affect health and how they can be unequal within populations. So the first thing we need to do is think about this word population. What do we mean by a population? Effectively, a population is a group of patients with a shared characteristic, so it's just something we can define them by. Now, most commonly we think of populations in terms of the geography, where they live. So a population could be all the people living in the same city or the same postcode or the same street. However, we could also think of populations in terms of people from the same ethnic backgrounds, or people who do the same job, or people who are roughly the same age, so we could break things up into groups of young people or older people. Another example would be university students at Sheffield would be a population, and they would have their own distinct health characteristics. When we think about risk factors within and between populations, they're not evenly distributed. For example, older people are more likely to have hypertension. South Asians are more likely to have diabetes. People with manual jobs are more likely to smoke. Now, when you hear statements like this, you need to think about more likely than who? What are we comparing them to? Are we comparing them to another population? Are we comparing them to the average for the whole population? And the next question you need to ask is, how much more likely? Does it really matter? Now, just as risk is not evenly distributed in a population, so disease is unevenly distributed, and this makes sense based on what we've said before. For example, heart attacks are much more common in manual labourers, and we've said before that smoking is much more common in manual labourers, so the risk factors and the disease profile fit each other well. Strokes are more common in older people. Why is it useful to know this? Well, firstly, for your individual patient, it helps you make your diagnosis. So somebody who walks through the door with a problem, you can think about the risk factors they've got and think about the health they're likely to experience. For the larger population, it helps us plan. So when we're looking at where to put services to make sure things are in the right place and the right services are available to the people who need them the most, we need to know about how health is distributed within a population. For example, how would we know how many physiotherapists we need if we didn't know how many people are likely to have falls or strokes? How would we know where to put more dentists' surgeries if we didn't know where the majority of disease and patients were? And finally, it's useful to know this because it helps to see if what we're doing is fair. And by this I mean, are the populations with the most problems getting the most services, and are the services appropriate for them? Can they reach them? This brings us to the concept of health inequalities. A simple definition of health inequalities is something different in terms of the health outcomes between two populations. The WHO definition, differences in health status or in the distribution of health determinants between different population groups, is widely accepted. The WHO also points out that health inequalities are preventable and unjust differences, and that people in lower socioeconomic groups are much more likely to experience chronic ill health and die earlier than those who are more advantaged. Now, the terms health inequality and health inequity are sometimes used interchangeably. But you need to be careful about this because some researchers tend to use the term health inequity to particularly talk about things that are preventable and unjust, whereas health inequalities they tend to use for differences between populations that aren't easily preventable. For example, the fact that older people are more likely to have strokes than younger people. Let's look at some examples of health inequalities. A baby born in the Democratic Republic of Congo is at least 50 times more likely to die in the first year of life than a child in Norway. This is obviously a massive difference. People in the most wealthy 10% of the population living in Westminster live on average 17 years longer than those in the least wealthy 10% of the population. Manual workers in Scandinavian countries are 3 times more likely to have lost all their teeth than people working in managerial roles in Scandinavian countries. All of these are examples of health inequalities. Health inequalities are related back to risk factors, and some of the things we talked about with risk factors previously looked at things that people do, but we need to recognize that there are much wider determinants of health. Things that make people healthy or unhealthy relate back to some important social risk factors. For example, do you have a job? Are you working in a safe environment? How well educated were you? How easy is it for you to access food, and particularly healthy food? What's your housing like? All of these different factors are broader things that determine people's health and actually have as much influence on health as genetic factors and age and gender. This brings us to deprivation, which I've called here the risk factor to rule them all. Deprivation confounds almost every other risk factor, and most risk factors that we look at will have an element where deprivation is affecting them. Now, the basic definition of deprivation is the damaging lack of material benefits considered to be basic necessities in a society. It's a complicated way of saying the word poverty or poor. Effectively, what we know from a health point of view is that people from poorer backgrounds have much worse health outcomes than people from richer backgrounds. This is a modifiable risk factor. It's not appropriate to think that deprivation is not something that can be changed. And Nelson Mandela pointed this out with his fantastic speech, where he stated that overcoming poverty is not a task of charity, it's an act of justice. Like slavery and apartheid, poverty is not natural, it is man-made, and can be overcome and eradicated by the actions of human beings. When we're thinking about deprivation and its effect on health, we can see that health is not evenly distributed across a society, and the more deprived you are, the worse your health outcomes tend to be. Here we've got 2 graphs taken from the Marmot report. The graph on the left shows your chances of circulatory disease, dying from circulatory disease or cancer under the age of 75, depending on whether you live in a more or less deprived area. And they've divided up the population into 20ths. So on the left-hand side of the graph, we've got the richer population, the least deprived, and on the right-hand side, the most deprived. The dark bars are males, and the light bars are females. What we can see here is that the rate of circulatory disease goes up sharply, particularly in males, as deprivation increases. It does the same thing in females, but to a slightly lesser extent. What we can use these graphs for is we can look at a gradient. We can look at how steep the incline is, and that gives us an idea of what the social gradient for this particular problem is. So for some things the graph will be pretty steep, and you can see here relative to the others, deprivation in males has a bigger effect on your likelihood of circulatory disease. Deprivation in females has less influence, and the gradient is shallower. And when we compare the difference between the effect of deprivation on circulatory disease and the effect of deprivation on cancer, you can see that deprivation has more impact on men in circulatory disease than it does in cancer. sometimes these slopes are called the slope index of deprivation or the slope index of inequality, and using this gradient can sometimes be helpful as a measure over time to see whether things are getting better or worse. We can also map deprivation out and map out the health impacts. Here's a couple of maps you've probably seen before. On the left hand side here we've got a map of Sheffield using something called the index of multiple deprivation, which is a series of many measures which try to work out deprivation in an area, and they measure things like the proportion of people who've got a job, proportion of people who are on benefits, whether they have access to a car, whether they have been educated to a high degree, etc., etc. And they put all of these measures together to get an overall deprivation score. And what you can see with Sheffield is it's a sharply divided city. You can pretty much draw a line between the more deprived northeast of the city and the more affluent southwest of the city. This has impacts on health, and on the right hand side we've got a graph looking at the infamous number 83 bus route across Sheffield. It starts off in the affluent southwest of the city and then moves through the city through some of the more deprived areas before going up into the slightly more affluent East Ecclesfield area. And what you can see is that when the map's starting off there in the Ecclesfield area, life expectancy for men 83.7 years, for women 86.3 years. By the time we've reached Firth Park, and the most deprived, one of the more deprived areas of town, that life expectancy has fallen dramatically, and for men 75.6 years. That's a more than 8-year loss of life expectancy, and similarly for women they've lost about 6 years of life expectancy in that distance. Why is it useful to map these things? This will help us to think about where the populations who have the worst health are in our community, and to think about how we provide services for them. Can we do anything about inequalities? The simple answer is yes, but it's very, very tricky. The most effective intervention seems to be wealth redistribution. And one of the best ways of doing this is through what's called progressive taxation. So effectively, in a country where richer people pay a much higher tax and poorer people pay a much lower tax, the inequalities seem to be narrower. And that taxation, the money raised by taxation, can then be used to provide people who have less with the things that they need. Another way we can think about addressing inequalities at a more local level is to think about where we put our services, and we need to make sure that we provide better services in the areas that need them the most. We can also target populations who will benefit the most, making sure that our services are near and appropriate to populations who are most likely to have health problems. That's the end of this quick visit through deprivation and health. If you want more information, there's some fantastic references here. The Spirit Level is an excellent book, and I'd recommend everybody have a read of it. If you want to read some of the chapters and parts of it, you can go to the website logged here. Another excellent resource is Gapminder, which if you go to the Gapminder website, you can play around with some of these things and look at the differences between countries. They've got an excellent graphing program that allows you to have a fiddle with some of the different settings and have a look at how health is distributed internationally. And then another really excellent resource on this is the Marmot Review. This was published by Michael Marmot in 2010, and the link there will take you to a download of the Marmot Review. Thanks for your time, and I hope you're getting on well with the course.